morning, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, and we're continuing the important discussion of respiratory emergencies. If you recall, last time we talked about upper respiratory emergency or upper respiratory obstruction, and the most common cause for it, be it viral croup. And just to recap, we said that when we think about the pediatric airway, we think about upper and lower. We think about the larynx as the midpoint, and anything that causes obstruction in the upper airway is going to cause an inspiratory sound. We call that stridor. Anything that causes obstruction in the lower airway is going to cause an expiratory sound. We call that wheezing. Easy, simple, done. Now, last time, if you recall, we spoke about upper airway obstruction and the most common cause for it. That was viral croup. Remember the inspiratory sound, the stridor, the steroids, the racemic, etc., etc., etc. Today, we're going to talk about probably the most common cause of lower airway obstruction, which is also a viral illness. We call that bronchiolitis. And it's the disease that hits us every winter and doesn't let go until the very, very end. Kids come in all the time, wheezing, retracting, abdominal breathing, in distress. They're all very small, so mom is very worried. And round we go. So let's talk about the disease that really we can do nothing for, but for some reason there's so much to talk about. As you know, kids with bronchiolitis are wheezing, therefore we're talking about lower airway obstruction. Some of us refer to bronchiolitis as the disease that only time can cure, because really we know nothing helps those kids, unfortunately. When I talk about bronchiolitis, I think the most important thing to do is, number one, realize what the definition is. So the AAP definition that I'm familiar with is wheezing in a child less than 2 years of age in the appropriate season, aka winter. So this condition is probably the easiest condition to diagnose. You see a child with cough, runny nose, congestion, who developed wheezing, aka lower airway obstruction. You made the diagnosis if the child is less than 2. He has bronchiolitis. So what is that? Basically, inflammation in the upper airway that progressed to the lower airway, aka the bronchioles. That is why it's called bronchiolitis. And when you have mucus secretions in an already narrow airway, because the patient is that small, that leads to that whistling, wheezing sound. It's almost always in the winter. Usually the premature kids and the kids with comorbidities suffer a lot more, but any child can get it. There's a whole lot to say, but unfortunately, not a whole lot to do. This is one of the most researched diseases in pediatrics. We know now that no medications help. We have tried them all. I think it's important to follow the guidelines, AAP guidelines for bronchiolitis, so that there's some homogeneity with regards to the treatment. And the clinical practice guidelines for bronchiolitis of the AAP are public information. You can find them, and it's very easy to follow. I like to read the summary that I created to my residents and my medical students that make it very clear and very easy. So here we go. Clinicians should not administer albuterol to infants and children with a diagnosis of bronchiolitis. Clinicians should not administer epinephrine to infants and children with bronchiolitis. Nebulized hypertonic saline should not be administered to infants with a diagnosis of bronchiolitis in the emergency department. So there you have it. I just quoted American Academy of Pediatric Clinical Practice Guidelines for bronchiolitis. They basically say, do none of the above. So what do? Suction, suction, suction. I suction kids with bronchiolitis all the time. I tell parents to suction kids with bronchiolitis all the time. Again, setting up the expectations, I say something like, Mom and Dad, feel free to suction your baby as much as possible, as much as needed. Sometimes if you suction a lot, you get a little bit of bleeding. That's okay. Most important is that little Johnny breathes comfortably. If I suction them in the ER and it's not helpful, I ask my nurse to do what I call deep suction. In our hospital, we call it red rubber. Those tubes used for suction are basically a piece of red rubber. And if I deep suction the child and he's better, that's great. We do a PO challenge and hopefully send him home. I do want to make sure I make the point that if you deep suction a child several times in order for him to feed and look better, that actually could be an indication for admission because, again, that is not something mom and dad can do at home. So I encourage you to entertain that possibility. Obviously, if the kid is hypoxic, I put them on nasal cannula and admit them. And if the kid has significant respiratory distress, this is something the nasal cannula is not going to relieve because nasal cannula does not have any pressure or PEEP. I put them on high flow nasal cannula, which really revolutionized the need for intubation for kids with bronchiolitis, and I admit them. Unfortunately, in my hospital, that means that they have to go to the PICU. Again, there are some important don'ts with regards to bronchiolitis. So those patients do not need antibiotics. Chest x-ray is not recommended. In fact, all the data shows that if you find bacterial infection in kids with bronchiolitis, it's almost always going to be a urinary tract infection, so you're better off doing a urine analysis, not a chest x-ray. Those kids do not need steroids, and ordering the respiratory viral panel for the most part is not very helpful. Which virus the patient has really does not matter. Certainly, COVID unfortunately changed this a little bit, but for the most part, if the patient is metapneumovirus, rhinovirus, or RSV causing bronchiolitis, that doesn't change a whole lot. There is an exception to that. When I see a child with bronchiolitis who's less than 30 days old, I do obtain the respiratory viral panel because I do want to know if this is RSV. Remember, there's a combination of RSV and apnea that can be life-threatening in babies less than a month old. So any patient who's premature, has comorbidities, or is less than a month old, I do recommend you check for RSV and admit him if it's positive. For those kids who go home, some of my anticipatory guidance includes watching for the respiratory distress, so I describe to the parents what do retractions, abdominal breathing, and nasal flaring look like so they can recognize those signs at home, and I make sure they watch for the feeding. I tell them it's okay to give Pedialyte for a day or two. Remember, Pedialyte doesn't really have any nutrition, so I want little Johnny back on the formula as soon as, but Pedialyte for a day or two just so he stays hydrated, that's totally fine. Watch for the urinary output, which is very easy because we're changing diapers. Let the fever be. The more fever the child has, the sooner he gets better. It's as simple as that. So if the baby is febrile but not particularly ill-appearing, breathing fine and taking the bottle, let the fever be. Again, unfortunately, some kids, many kids with bronchiolitis do have to come into the hospital. So if the kid is hypoxic, if the kid is not tolerating PO, if there's respiratory distress, remember those are the indication for admission for all kids with respiratory problems. Specifically for bronchiolitis, I talk about 3 bronchiolitis exclusives. So remember, if the kid needed deep suction repeatedly in order to look well, remain oxygenated, and take something PO, that is something that you should consider as indication for admission because that is not something parents can do at home. Remember, we said if the patient is RSV positive and is a fresh newborn, less than a month old, the risk of apnea is just too great. I admit those kids. And then there's something I call the 3 to 5 day rule. I personally always learned that bronchiolitis usually peaks or gets worse around day 3 to 5. So if I see someone, a baby that is maybe 6 months old, his respiratory rate is at the 60s, he looks okay, the PO is not that great, and he's day 1 or 2 of illness, I admit those kids. My thinking is possibly, likely, the child will get worse tomorrow and will have to be back. If I see someone who's borderline like that, taking good PO and is day 5 of illness, I'm probably going to send him home. Now, obviously, things like mom's level of comfort, follow up with the primary care, and mom's level of understanding of the situation and what she should do should also be taken into account. Lastly, I want to talk about something that unfortunately strikes us every few years. So here's the case of a 2-month-old who's presenting with wheezing and tachypnea. He has no fever, no runny nose, no congestion. It's July, and like I said, he really has no viral symptoms. This is a time when I strongly consider the possibility of congenital heart disease, and I do what I call the PEM echo, which is really a chest x-ray and an EKG, since I can't really get a reliable echo in the pediatric emergency department in a timely manner. I'm looking for that boot-shaped heart or that egg on a string heart or all those funky heart shapes of congenital heart disease, I do an EKG and I speak to my pediatric cardiologist. Every once in a while, I hear of a colleague who saw a patient in the winter with wheezing, diagnosed bronchiolitis, and unfortunately made a mistake and missed the diagnosis of congenital heart disease. So keep in mind, kids with congenital heart disease can definitely present with tachypnea and wheezing, but they don't have the viral symptoms. And if the kid presents with bronchiolitis outside of winter season, I think it's important to entertain the possibility of other diagnoses. And that is it for today, guys. Thank you very much for listening. I appreciate it. I hope you find this podcast helpful. Please feel free to check out my website at www.pemrules.com. Submit any feedback. Let me know if there are any topics you want to discuss or hear about. Love to hear from you guys. Have a great day.